Good morning, everyone. My name is Anna MOLTO. I'm a rheumatologist based in Paris, in Cochin Hospital, and I'm also a clinical researcher and epidemiologist in Université de Paris. It is my pleasure to present today a clinical appraisal of treatment efficacy evaluation, and we thought it was a good idea, given the current times, to take the example of hydroxychloroquine and COVID-19. First, the objective. What's the objective of critically appraising an article, evaluating efficacy or any other whatsoever? Well, we have to evaluate the scientific validity, which is the reliability of the results, and also the clinical interest of the results which are presented to decide whether or not we're going to change our clinical practice. And that's based in the quality of the evidence that is presented to us. Normally we grade evidence between high and very low. Very high evidence, very high quality of evidence, is when we are very confident that the true effect lies very close of the estimate of the effect that is presented in the study, where very low quality of evidence is when we think that the true effect is quite likely to be quite different from the estimate of the effect that is presented. So normally we grade the type of study based on the quality of the evidence they provide, and the highest quality of evidence are RTCs, followed by cohorts, case controls, cross-sectional studies, and case series, and expert recommendations. Well, it's not that it's very low, it's just that it's not evidence, it's just an opinion, and it's very important in some settings, but we cannot use it to grade the quality of evidence. It's not evidence. So if one wanted to be very simple, one could divide the type of study in RCT, R high quality, and all the rest is low quality. All that is observational is low quality. Well, the problem is that that's not so easy, because it might be a randomized clinical trial, but there might be many factors that may hamper the quality of the study. For example, the risk of bias, the imprecision of the estimates, the publication bias, the inconsistency of the results of other trials, etc. So one could have a randomized clinical trial, so supposed to be the highest quality of evidence available, but several factors like, I don't know, the bias of the selection of the sample of the population included in the study, that the results provided have a huge confidence interval, so that we end up with very imprecise results, may hamper the quality of the study, and then we might end up with a randomized clinical trial, which is in fact low quality. But we can also have the other way around. That means that we can have an observational trial that has very strong associations, a dose-response effect, the results are comparable to other randomized clinical trials, and then we might end up with an observational trial, which is not exactly the highest, in theory, the highest quality of evidence, but with a quite high level of evidence due to the good parameters of the study. One has to have some reflexes when reading an article aiming to evaluate efficacy of treatment. It has to be easy to identify the question. If it's difficult to know which is the question that the authors are aiming to answer, we'll have a problem. The question has to be a real research question, of course, based on the current available scientific context and information, and it has to be presented with the PICO study. It has to be easy to find which is the population, what's the intervention, what's the comparator, and what's the outcome. And in theory, one study equals one question. That's particularly true with trials aiming to evaluate the efficacy of a molecule which has not been evaluated till now, but that can be also applied to other settings. Also, when looking at the structure of the manuscript, one should be easily find the introduction, methods, results, and discussion structure. That's easy. In the introduction, of course, we have to find the background and the justification of the study. Why should this study be conducted? The pick a question and the primary objective should be clearly presented at the end of the introduction, or in some review, in some journals, there's a specific chapter which is called objective, but otherwise that should be placed at the end of the introduction. Whereas in methods, we have to find the study design, the population, the intervention, the outcomes measures, and the analysis. In the results, we have to find the description of the population included, and the results of the primary and thereafter secondary outcomes, and of course the discussion. In theory, as I said, one trial answers one question, and within the manuscript and the trial, a primary objective should match the primary outcome, which should match the primary result or main result. The primary outcome has to be objective, relevant, and reproducible, and we will see that that's not so easy sometimes. The sample calculation is really, really important. We have to check within the manuscript that the sample needed has been calculated and achieved. That means that if patients, authors needed, 300 patients per arm to achieve a power of 80% and an alpha risk of 5%, and in the end they only included 100 patients per arm, when that's a concern. An author should either not publish or end the study, or still recruit, or at least acknowledge this, and you have to be aware that therefore the power of the study might be underpowered, because that's the power they estimated was calculated for 300 patients and not for 300 patients per arm, and not for 100 patients per arm. And also very importantly, even if it's achieved, one should be able as a reader to recalculate the sample size they say they have calculated. That's very important. So the numbers are available for you to verify that indeed that's the number that was needed. As for the analysis, some hints, some things that you should absolutely check. In theory, and in 90% of the cases, intermediate or interim analysis should be prescribed, unless there are some very specific situations, and if it's specified in the protocol upfront. Otherwise, they inflate the alpha risk. And that's also true for post hoc secondary analysis, if they're not anticipated in the power calculation of the study. As for the type of analysis, it's in randomized clinical trials, it's very important to look at how the population was analyzed. Why this is important? Because in treatment efficacy evaluation, randomization actually ensures that the two groups or three groups, depending on the arms, but that the groups of treatment are comparable between them, because treatment is allocated by random. That's completely different from what happens in observational cohorts. In observational cohorts, when it's the physician deciding the treatment, it's quite likely that based on his clinical knowledge, clinical reasoning, a certain group of patients will receive a certain treatment and another group would receive another treatment. For example, older patients would receive less invasive treatments perhaps, whereas patients with more comorbidities will have less invasive measures. So we might end up with groups comparing treatments, but the problem is that the groups at the very beginning of the evaluations were already very different, and that is overcome. That is called prescription bias, and that is absolutely overcome at randomization, because the physician's clinical knowledge, clinical a priori, is not taken into account. Patients are randomized to the treatment arm by the process of randomization. And so the way after randomization's data is analyzed is important, because most of the trials are analyzing ITT meaning intention to treat, and that means that patients are analyzed in the group that they were randomized to. It might be that in a study, due to a side effect, patients would change from one arm to the other arm. In an ITT analysis, patients will be analyzed in the group they started, regardless the treatment they received. Whereas in the per-protocol analysis, only the patients who follow the protocol are analyzed, who follow the protocol during the study. And that hampers the comparability that randomization ensures. By ITT analysis, by definition, the groups are still comparable, but mine might argue that there, if half of them did not receive the treatment, what's the value? But in the other way around, the per-protocol analysis might lead to absolutely not comparable groups, and it's the job of the authors of the manuscript and of the trial to demonstrate that still, despite the per-protocol analysis, groups were comparable when they were evaluated. Otherwise, it hampers the interest of the randomization. And I will finish with two examples. As I said, we thought it was a good moment to take the example of hydroxychloroquine efficacy on COVID-19. And it's also in their site, in Medrix, where I got these two examples. They are preprints. That means that these two papers are not peer reviewed yet, but the results and the full manuscript are available for for physicians to look at it. But as disclaimed also on their site, it should not be used to guide clinical practice. But that's not what we're going to do today. We're not going to decide whether you should prescribe hydroxychloroquine to your patients with COVID. We will just look at the methods and the methodology and how the studies were presented. First, an observational trial. As I said, observational trials are low quality of evidence, where they're meant to be, or they're supposed to be low quality of evidence. But I wanted to present this one because in this setting, that's a very, very high quality observational trial aiming to evaluate efficacy. It's a trial run here in France with a very clear objective, very well presented, to evaluate the clinical effectiveness of hydroxychloroquine at a daily dose of 600 milligrams in preventing the admission to intensive care or death by any cause in patients who are already hospitalized for COVID-19. As I say, it's an observational cohort of patients who were treated or not treated, depending on the physician's criteria. That's what we discussed just before. It's an observational trial, and then that's physician, based on the clinical knowledge, reasoning, decide to prescribe a treatment or the other. That's what we call prescription bias, but that's okay. That's how it is. The inclusion and exclusion criteria here are very well described, so it's very easy to gather the idea of which populations we are talking about. And the statistical analysis is really, really well done here. The sample size is not calculated, but that's okay. It's not an RTC, so that's fine. And the most important thing is that if you wanted to calculate the power of the study, you could do so, because the authors provide all the data that would allow you to calculate a post-hoc and afterwards power of the study if you wanted to do so. So that's very good. And the other very good thing is that they absolutely disclaim what's the limitation of evaluation of treatment efficacy in a cohort. And they use very sophisticated statistical techniques to try to overcome this prescription bias by reproducing somehow the process of randomization by actually gathering the propensity of a patient to receive the treatment, which is actually what the physician does in his mind, to take all the parameters and make a decision. So they reproduce what were the conditions that led to the patient to receive that treatment or not receive that treatment, and they apply with a very sophisticated method, with this inverse probability weighting by the propensity score. Then they give different weights to the patients receiving and not receiving the treatment based on this propensity score to get a comparable sample and reproducing somehow a randomization setting. And they do present really different options. They tested which one was more achieved a better balance between the groups. So this is very, very thorough and perfectly executed. So very, very nice and of very high quality, actually. To a very clear result on the primary outcome, which was that there was no difference between patients treated and not treated by hydroxychloroquine in the outcomes, which was the admission in intensive care unit or death. So here, an example. It's not a randomized clinical trial, but very clearly presented, statistical methods trying at the best to overcome the prescription bias, and a very clearly presented result. And here it's a counterexample where this is a randomized clinical trial evaluating the efficacy of hydroxychloroquine in COVID patients, was open label, where the endpoint was the 28-day negative conversion rate of SARS-CoV. The design is pretty easy, as I said, open label randomized clinical trial, hydroxychloroquine 1,200 milligrams versus usual care. And what I don't find quite relevant here is the primary outcome, because it's a negative conversion at 28 days. With the data that we have now, and that it might be that that was not known at the time they run the study, that's also possible, but nowadays 28 days might seem too much when we look at the data of conversion rates in COVID patients. Furthermore, they do present the sample calculation. They need 180 patients per group, so 360 patients in total. And when we look at the results, well, the sample included is 40% of what was needed. So again, you can always present with excuses or explanations. It might be that it was difficult to recruit patients, or it was in the when cases were lowering down and the curve was flattening, and then we couldn't include. But regardless, the explanation, only 40% of the sample estimated needed was included. And that's how it is. And the primary outcome is not different, but that's fine. Negative results should also be published if they're clinically relevant. Not only positive results should be published. The problem is that we don't know whether it's negative and not significant because it's underpowered. Quite unlikely, because when you look at the numbers, at 28 days, 85 and 81% of the patients were seronegative converted. So they also present some positive results in secondary outcomes and subgroup analysis. So as I said before, beware of these subgroup analysis positive results. They were not taken into account into the sample calculation, and on the top of this, the sample calculation was not met. So yeah, it might be that it's a randomized clinical trial with a pretty relevant question. I'm not so sure about this outcome. I'm not so sure about the power of the study, but even underpowered, I don't see a major difference between the two groups, and that might be the choice of the outcome. So we have here a randomized clinical trial supposed to be very, very high quality of evidence, where we are a little bit disappointed on the parameters that I described, the sample size recruited and the primary outcome, which I think was not really the most relevant here. So three take-home message. Normally, at least in drug RCTs, one question equals one study. And within the study, the main objective has to meet the main outcome, that has to meet the main result, that has to be crystal clear in the manuscript. The sample size is calculated on the main outcome, and you should be able that the calculated sample size matches the included sample size, and you should be able to reproduce the calculations with the data provided by the authors. And as we saw, of course, in theory, in efficacy trials, the RCT is the gold standard. But It is important to clinically appraise your articles, because a robust and consistent, reliable observational trial applying methods to try to overcome the prescription bias might be higher quality of evidence than the biased RCT. And I would like to thank you for your attention, and I wish you all to stay healthy in these very particular times. Thank you.